A lot of this boils down to there being a lack of consensus on what the ideal genomic test design is, sort of what genes are included, what regions are covered. And then in addition to that, what reporting standards should look like. So how do we report limits of detection? What kind of alterations are we reporting? Do we include metrics like tumor mutational burden or microsatellite instability? And then to complicate this, we have germline and somatic test options. And then for the somatic side of it, you have different DNA sources, namely tumor tissue or liquid biopsy plasma circulating tumor DNA. And so working with the Prostate Cancer Foundation Precision Registry, we've sort of written a guide to help address some of these challenges for healthcare providers. Beyond test availability in the clinician's jurisdiction and familiarity with that test, I think you really need to stop and consider what your testing goal is. Are you looking to identify prognostic biomarkers or predictive biomarkers for targeted treatments, for identifying hereditary cancer germline alterations that would have familial implications? And then once you've identified what the goal of the test is, that narrows down the test options significantly. And then from there, I think the next consideration is what is your DNA source and what is the timing of testing? So we would advocate that if the patient had metastatic castration-sensitive prostate cancer, that germline and somatic tissue testing be done in parallel at diagnosis. But as the patient has progressed to castration-resistant prostate cancer, in addition to the germline, you could consider metastatic biopsy or a circulating tumor DNA test so that you have sort of more recent tissue. Circulating tumor DNA is ideal at the time of progression for metastatic disease. That's where you're going to have the most power to detect alterations. But tissue would be favored if the patient was currently experiencing response to treatment. So taking the patient context into consideration as well. I think it's important, obviously, to involve hereditary cancer specialists when you have pathogenic germline results. But beyond that, genomic scientists like myself can really aid with education. Genomic literacy and interpretation of these genomic results is often cited as an obstacle in surveys of healthcare providers to optimally implementing precision oncology approaches. And so that's part of the reason that the Precision Registry wrote this paper, is to help with that genomic literacy education. Together, I think, these interdisciplinary groups, we can apply the best pressure to commercial assay providers for improvements on assay design and advocating for more transparent reporting. I think, something that's not fully dealt with at the moment is the lack of racial and ethnic diversity in current genomic reference databases. So what this actually means is that when non-Caucasians have genomic tests done, there's an increase in variants of uncertain significance. And so we need contributions from clinical and commercial providers to increase representation in these variant interpretation databases. The Precision Registry specifically is working very closely with Veterans Affairs in the United States, collecting information related to PARP inhibitor use, and that would increase the proportion of patients of African-American descent. So that's just one method. The other aspect to this is that obviously patients that are in large urban areas and close to academic medical centers are more likely to participate in genomic testing and have access to that. Their clinicians might be more familiar with it or have more options available to them. But liquid biopsy is really enabling democratization of genomic testing because people in remote communities can send samples in through mail, and they don't need to necessarily be in a large academic center and have tissue biopsies done. One of the things that a lot of the commercial assays do not do is profile germline DNA in parallel to the tumor DNA, and they often cite cost reasons for this. But patient-matched white blood cell sequencing really should be standard, and that enables the distinction of germline, somatic, and clonal hematopoiesis-related variants if you had a liquid biopsy. But beyond, including the germline, I think we really need to think about what are standardized reporting practices that we want to see. And this is a matter best addressed through regulatory agencies like the FDA and Health Canada and the EMA, making sure that to get a genomic test approved for access to patients, that we have a minimum requirement. So I think you need to critically appraise the results of the genomic test in the context of the test you've chosen, its reporting standards, its limits of detection. Tumor fraction is a key variable, and if it's not directly reported on the assay report, then you can infer it from the variant allele fraction of the mutations that are included. And tumor fraction actually constrains the type of alterations that can be determined. So copy number alterations require a much higher tumor fraction than does a simple single nucleotide variant. And this is commonly affecting circulating tumor DNA assays, but it's important to be aware that this also affects tissue assays. They can have low tumor fraction, and tumor fraction is different from cellularity. It can be hard to predict pathologically whether or not the tumor fraction is going to be sufficient. And then there's the fact that you have these mutations reported. Often they are listed alongside potential targeted treatments, but what the reports often lack is information about whether those mutations are subclonal. And so how effective would that targeted therapy be in this tumor? And they may or may not include pathogenicity scores, but there's a lot of ways to determine pathogenicity. So thinking about that, how was pathogenicity determined? Maybe doing your own evaluation through some of the various databases that are available before taking action on a potentially targetable alteration. And then for people utilizing ctDNA, really be aware that clonal hematopoiesis is a confounding factor, and whether or not your assay does identify clonal hematopoiesis related variants. So our paper includes mock reports that guide readers through the evaluation of some of these scenarios. But I'd just like to highlight that while the paper focuses on prostate cancer and treatment with PARP inhibitors, the information and the framework that we provide for critically evaluating genomic testing results, that can be applied more broadly to targets beyond PARP, to other GU cancers, and some even to other cancers broadly, pan-cancer. And we know that precision oncology is gaining a lot of momentum. We expect that genomic testing will be more widespread in the future. So I think increasing genomic literacy, improving test design, and reporting standards is really going to benefit our community in future.